Hello, everyone, and welcome to the Coronary Corner. It is our great pleasure, together with my co-moderator, Yader Sandoval, to introduce Dr. Maksymilian Opolski, who is the director of the C program at the National Institute of Cardiology in Warsaw, in Poland, where he also heads the scientific committee. Dr. Opolski has had tremendous impact on complex PCI, but specifically on CT, and he was one of the first ones to create a score for CTO PCI based on CT findings several years ago, and has continued to use CT in his daily practice. And more recently, he was the lead author for the Polish Society of Cardiology statement on how to use coronary CT for planning PCI. So, Maksymilian, welcome to the podcast. It's a great pleasure to have you with us.
Thank you, Manos. Thank you, Yader, and it's great to be with you guys.
Well, we're thrilled to have you here. Thank you for joining. To me, the first question, as a leader in complex coronary intervention, CTO, how did you get started in CT? Can you share with us your journey of how did CT started? What has led to what?
It all started quite a long time ago, so I'm already quite old from that point of view. So I think I was finishing my medical studies in Warsaw, Poland, and we have basically these scientific circles which are belonging to some sites, like scientific sites in Poland. And I was part of one of these scientific circles, which was actually attached to my current hospital, which is National Institute of Cardiology in Warsaw. And the lucky thing was that I was in the right place, in the right time, because this site, our site, just got the CT, which was a dual source 64 slice detector CT scanner that was brand new. And the director of our institution was a kind of visionary. He decided that this CT scanner is going to be partly led by interventional cardiologists. So there were three guys who were already senior interventional cardiologists, and they were very hooked on science. That's how it started. Hooked up basically cardiac CT in 2008. That was very early on. I think it shook up the field of interventional cardiology at that time. I started doing science and some scientific projects at that time, and I really got interested. I wrote abstracts. I sent abstracts to the SCCT conference, which was a different word for me. It was very interesting, and it got accepted. I started traveling there, presenting the results. I met a lot of guys who impressed me, like I call it the gout mountain, like Stefan Achenbach, James Min, Jonathan Leipzig, and I started talking with the guys, and I was impressed. And that was the time when we basically started thinking about CT-guided PCI. So I think we were the first adopters of CT-guided PCI, even though not many people believed in that. I can basically recall the paper, can you believe that, from 2008. It was published in CCI by Harvey Hecht, who unfortunately passed away, I think, early this year. That was a cardiologist, kind of visionary, far-sighted, forward-looking guy. And the title of this paper was The Applications of Multi-Slice CT to Guide PCI. How did we ever do without this one? And we were reading this paper, hell, we were impressed. And that was the minery for ideas for following science. And then a colleague of mine started a very small randomized clinical trial, randomizing people to angiography-guided PCI versus CT-guided PCI that was mainly anatomy-based with intravascular ultrasounds endpoints. And that was quite interesting. And then we did the same one, a group of us, in bifurcation lesions, and then brought the same idea to Amsterdam. And mainly the results of these papers were that there's not much of a difference if you do CT-guided PCI based on anatomic kind of variables compared to invasive cath PCI. So these two were basically equal.
Thanks, Maksymilian. So again, you were one of the early adopters, which is tremendous and helped push the whole field forward. And tell us a little bit about the story. How did you decide to create the CT-RECTOR score? How was your motivation and your thinking for doing that at an early stage when this was not commonly done?
Yes, so basically it comes from the time point I was very interested in cardiac CT and also interventional cardiology. And basically I knew I want to do both from the very get-go. And then I wanted to go abroad and train abroad. And I went, and I was lucky enough to basically go to Germany, to Bad Nauheim. And actually, the person who helped me so much at that time was Stefan Achenbach, whom I basically met at SCCT, I think, in Las Vegas, 2015, or even a year before. And then I went to Bad Nauheim, and I was about to do research. And the main topic of my research, even though I was not much interested on CTO PCI at the time, was to develop a CT-based score to basically predict time-efficient antegrade wiring within the 30 minutes time. I gathered data from 4 sites. That was Bad Nauheim, Gießen, Erlangen from Stefan Achenbach, and Warsaw from my side, and we developed a score that was huge of our work, prospective study, but still quite demanding, and we published this paper which basically developed the CT-based score, and I think that's one of my greatest scientific achievements so far. It's quite nice when you go for a conference abroad, and particularly in Asia, they present a case, and you can see on the first slide, the CT-RECTOR score was 2 or 3. So that gives me kind of pride.
Wonderful. Congratulations. Phenomenal work. But tell us a little bit then. I know that you did the training on CTO and you've done the phenomenal work in developing your CTO program. How do you use CT right now? In your practice, you do a lot of complex CTOs, bifurcations, other things. How do you actually use CT to help you plan your procedure?
Yes, I'm lucky enough to work in a site which is kind of high volume site with regard to CT-guided PCI. So we do a lot of CTs. And the reason for that is that we have scientific background. That's number one. We do have data, and we are gathering much more data for basically the use of CT before going to the cath lab and also within the cath lab. And 3 CTs could reimbursed in my country. Altogether, we have 2 CT scanners. That gives me kind of opportunity to scan patients before they go to the cath lab. So I think like 80% of my cases, cheap cases altogether, not only CTO PCI, but complex PCI cases, get CT before even entering the cath lab. It's a kind of low-hanging fruit data. It's manufactured, right? Why not to use that, and why not make the best out of the data? I think the greatest benefit of cardiac CT is that you can plan your procedure better compared to invasive cath. And it always reminded me of the words of Dwight Eisenhower, who used to say that plan is nothing, but planning is everything. I never basically understood these words until when I got interested in cardiac CT, and basically means that your plan, if you plan your procedure based on invasive cath, might go wrong because your CTO, your bifurcation lesion, your calcified lesion may not necessarily follow your plan, right? And then your plan might not work the very minute you're gonna implement that. But it's all about this kind of process of planning so that you have plan A, plan B, plan C, and maybe plan D behind your belt. And I think you're going to be able to get so many plans, like in the military, for example, based on CT, because it's going to show you much more things compared to crude and plain coronary angiography.
This is just great. And the other thing that I'm very interested in as you share some of your insights is that I think you said there 80% of your cases has CT, which is a tremendous percentage. We see a lot of heterogeneity in the use of CT globally. I think I was looking at a paper from Japan that I think it's 20% of cases. In the US, it's a huge country. There are some places that are high volume, but I think the number is probably single digits in the US as a whole country. And so the question that I have for you is, maybe you can share a little bit more. I know you had this, as Manos alluded, this Polish cardiac statement, the CT-guided PCI. Who reads CTs in Poland? Is it radiologists? Is it cardiac imagers? What elements have come together to provide this environment that has really facilitated the growth of CT-guided PCI in Poland at your center? What has led to that growth?
So, great question. First of all, I think I come from side, and I'm very fortunate to have these kind of 2 CT scanners. We do a lot of science, so we are center of excellence for CT. So in a way, I'm biased, right? So don't think everyone in my country has these kind of opportunities, because that's not going to be true. So that's number one. Number two, I have to admit that CTs, I think, like in UK, following the NICE guidelines, quite well reimbursed. And from that point of view, we have a great opportunity as a country to follow that and take cardiac CT to the forefront of diagnosing and then diagnosing coronary artery disease. So that's point number two. Now, point number three, and I'm responding to your question, in Poland, it's still, and I think it's going to be like that, the radiologist who is going to put the final dot on the result, right? But I think in a way we've been able to develop this kind of repartee between radiology and cardiology in our country, because I think it doesn't really matter which kind of specialty you do have, like whether you are a cardiologist or radiologist or even, I don't know, a psychiatrist. If you are hooked on hell-bent on doing and reading the CT scans in the best way, if you're really interested in this kind of stuff, I think you can take it to the best way to basically benefit your patients. And I think that's the kind of success story in mind.
Wonderful. Maksymilian, tell us a little bit about your day-to-day process. Do you do co-registration? Do you review the CT immediately before the complex procedures that you do? How often do you plan before the CT and then you change your opinion with CT, or vice versa? Do you look at the angiogram first and then go back to CT and make the plan? Tell us a little bit about all these technical, the practical things, how you use it on your day-to-day.
Yes, anytime I do have CT, and I told you I have CT 80% of our cases, and I don't look at this CT, I feel guilty in a way. So I think it's a bad habit not to analyze CT before any kind of complex PCI, which should be the case, I think. So most of the time I try and tend to analyze CT before I see coronary angio, because then I'm less biased. And then this kind of, I think it should be compared to a three-dimensional chest. You look on CT, I do it in the cath lab because we're lucky enough to have a workstation in the cath lab. So I don't have to go to the radiology department anywhere else. So I sit in the cath lab, I just upload the cases, which is very quick.
Which workstation do you use? Which workstation are you using for your cases?
We use Sandoval. We also have CTO guidance in the cath lab. It's also mounting, easy to operate. It doesn't take much time. There are not many buttons like on a bank 737 or anything like that. It's very easy. And then I start planning my procedure. It's difficult to explain in words what goes through in my head, but it's mainly, I think, the comparison with three-dimensional chess is the best way. You develop the scenarios which might happen, right? So starting from guide selection, right? Although in complex PCI, we mostly use EBU and Amplatz-lab guides. So I do think personally, it's not much of a great use apart from very few cases, but these few cases might make a big difference where you have some kind of anomalous origin of coronary artery gonna intervene on. And then I like looking at carved NPRs to develop my strategy. I look at the stent size, the stent length. In CTO PCI, I develop my first strategy, whether it's going to be antegrade wiring or whether I'm going to have a low threshold to jump in antegrade dissection reentry or retrograde approach. And then I look at the calcium, of course, which, for example, it's much easier when you talk about specific cases, right? When I approach a CTO case and I see a heavy calcified proximal cap, I think about puncturing, I was guided. But then I have a very low threshold to take a stiff wire, right? Because I know from the very get-go. So I can even say to technician, we're going to take this kind of microcatheter, we're going to take Gaia Next 3 or CP12, we're going to puncture the cap, and now looking at the plug beyond the proximal cap, and for example, finding out there is not much of a calcium beyond, I know I'm going to de-escalate, right? So all of these steps are prepped, and you get this kind of preparedness beforehand. And in case that something might go not the way you want to go, I'm prepped as well, right? So I know it's the process I told you about planning going in my head, I know my next moves in most of the cases which might happen. So it's basically like playing three-dimensional chess.
As you mentioned some of your thought process, I think there's an important philosophical question. Why do we do CT-guided PCI? I think it's something that some of us have discussed. Do you advocate, and in your experience all these years that you've been doing it, do you feel the primary message is that we do this because we're improving clinical outcomes? Or do we do it just because it improves procedural efficiency? As I think many of us, as you pointed out, identify a value in the use of CT for pre-procedural planning. But as this grows, I think this is a question that adopters might ask. So what in your experience is the primary value?
Yes, I'm also a kind of, at least I struggle and try to be a clinical trialist. And being a kind of clinical trialist makes you more skeptical to things. I'm not going to give you like a stunning answer that I do believe now that we have data, it's going to change clinical outcomes. Because I think you have to follow this kind of approach with grain of salt. But I do think we do CT because it's a great tool to basically rule out coronary artery disease. It's also a great gatekeeper to the cath lab with FFR CT coming into play. These kind of AI algorithms, they basically change the path and they change the way we treat patients. Now, regarding to the very CT-guided PCI, I think we do have data and we're going to collect more data that it's going to reduce time of your procedure, reduce the amount of contrast, at least in some kind of populations like patients after CABG. I'm sure it's gonna improve patient satisfaction, right? Because you're gonna have a shortened procedure, you're gonna get something I call targeted PCI, particularly in post-CABG, right? So you're not gonna look for all the grafts without sense. So you're truly hitting the nail, and it's gonna improve procedural efficiency. Regarding the clinical outcomes, I do think we are not there yet, so we need to get more data.
Thanks, Maksymilian. And tell us also a little bit about the document you just published with the Polish Society, which is wonderful. I think it's good for every society to develop their own guidelines because also it creates a lot of publicity and I think increases the awareness of this technique, which still, I'm not sure about Poland, but in the US, there's still a lot of room for growth and improvement. So tell me what inspired you to create this document? And then what were the key messages from the consensus document you just published?
Yeah, great. Basically, we decided, because that was, a joint group venture in a way, we decided to publish this document as a group of Polish Cardiac Society because there was a need, unmet need from the society. People are very much interested in cardiac CT. It's well reimbursed in Poland, and people think that should be developed because there are there is a tsunami of interest in the uptake of cardiac CT in my country. So there is a need. And we wanted to respond to the kind of unmet need and find a sweet point in that. And then I think there is also a quite high number of people focused on complex PCI in my country, and being outside of the structural part and structural field, there is this kind of desire to improve your outcomes and get into something interesting. And having said that, many patients coming to the cath lab get CT beforehand, at least I think more compared to other countries. In my country, we decided to write this kind of consensus to guide people, particularly both interventional cardiologists, but also general cardiologists and radiologists, how to deal with these patients, what kind of basic level CT you should have at least to go for this kind of CT-guided PCI. And mind you, it's not only concentrated on CT-guided PCI, but also on, how to gatekeep and keep patients outside of the cath lab, because still I think the greatest benefit and value of cardiac CT is that it serves as a great gatekeeper for sending patients to cath lab. And we have this great disruptive technology called FFR CT, which is already included in the European guidelines, even though it has class 2B indication. We really wanted to touch on this one as well and to create standardized fashion how to run and start a CT-guided PCI program in your center. And following this document, we also started a lot of education in my country. So the Polish Cardiac Society, particularly the Association of Cardiovascular Interventions, is very highly focused on running these courses where we basically train people from all the country with a lot of workstation how to do CT-guided PCI.
Congratulations on this document. It's just a wonderful review. One thing that captured my attention of the document was your section on training and certification process. So I'm wondering whether you can elaborate on that a little bit for the present and future. At least in the US and I think in many other parts of the world, I feel that there is a training and certification process for radiologists and cardiac imagers that are like professionally reading the CT to give you a read of the CT for diagnostic purposes. But I guess since this is for PCI guidance, what are your thoughts on this training process for the interventional cardiologists? Are you advocating that interventional cardiologists should complete some sort of a training, or how do we say that they are prepared to start doing this in their own practice independently?
Yeah, good question. So that was basically one of the aims of this document. Unfortunately, we are not there yet. So we tried with this kind of paragraph you nicely alluded to create kind of a framework for people who are interested in CT-guided PCI and on training people in following the path of cardiac imagers with regard to CT. The main aim of our kind of society is to establish a kind of training which is going to be very structured in the future, and at the end of the training, which might be theoretical, the first level, and then you go into the practical part, training and fulfilling the particular number of cases in high volume centers to get these kind of levels, mimicking the CCT levels, to get a kind of ability to evaluate and the results of cardiac CT in general, because it's not only about coronaries, you might have incidental findings, which might be very important for the patient and his pathway in the future, which are the attribute of radiologists nowadays. So we are still struggling to develop this kind of path to involve more cardiologists, whether they're going to be interventional cardiologists or general cardiologists focused on CT, to get this kind of ability to be involved and creating the results.
Thanks, Maksymilian. Again, I think all these efforts are wonderful, and this is where the future is going to come. And then before we finish, maybe give us a couple other thoughts on how you use CT. I know for CTO, you've done extensive demonstrations, you have the score and everything, but how do you use it, for example, for calcium or for bifurcations? Are there any specific things you look for in these two subgroups that help you change your plan from what you were going to do?
Yes, bifurcation. I think in bifurcation PCI, the key thing is whether or not you're going to compromise your side branch, right? So it's mainly about choosing and selecting between provisional approach or two-stent or one-stent plus DCB strategy. So that comes to my mind, and we also published quite a lot about that. Even though that was retrospective, it's called CT Precision Registry. We got and collected 400 bifurcation lesions, and we found out that once you have a plaque, particularly low attenuation plaque at the very side of the ostium of the side branch, you basically run a higher risk of side branch compromise during your provisional approach. Regarding to the very specifics, bifurcation PCI, if I see a huge plaque at the side of the ostium of the side branch, particularly when it's low attenuation, and then I'm more inclined into two-stent, or nowadays more often DCB plus one-stent strategy, right? Also, many things coming to play. I think on CT you can see the plaque with regard to the side branch in much more details compared to invasive cuff. You can see the angle, you can select the angle. You also can see the plaque before the very side branch, which is also very important regarding the potential carina shift. And then you can implement the FFR CT part, which we use in a kind of scientific manner, but I think it makes a lot of sense for bifurcation PCI as well. And then you combine both of these parts, like both anatomic and a physiologic approach. Suppose you have FFR CT in your lab, and you measure FFR CT, and then you have this FFR CT stenting platform where you can not only induce ischemia, but also you can place a virtual computation stent and see whether or not you can relieve ischemia. And you measure FFR CT in the main branch, that's positive, and you also measure the FFR CT in the side branch, and it's kind of borderline, but you can see a high plaque in the ostium of the side branch. To the worst, it's low attenuation. And then you say, okay, the FFR in the side branch is borderline. I have quite a high risk of side branch compromise. So when I compromise my side branch, the FFR CT is going to be lower. So I have a very low threshold to basically go for pre-dilating that side branch and any kind of two-stent strategy. Now, to make it short regarding the calcium, I think having the luxury of photon counting CT, which we do have in our side, changes the game completely. I think it flips the script. And from the point of view, we do have some data that, having this nasty looking calcium, which has higher attenuation or negative remodeling on the calcified plaque, and also the cross-section with more than 270 degrees of calcium, that are the predictors so far, which going to predict the need for mechanical atherectomy during your PCI. So anytime I see these kind of features, high angle on the cross-section, high attenuation, mean attenuation value, which is more predictive than the maximal attenuation value, and this kind of a negative remodeling at the very calcified plaque, or even the kind of C-shaped calcium which goes through the calcified plaque, then I'm more inclined to do any kind of calcium, debulking techniques.
Before we wrap up here, I have to ask you something before, and I would just like to you have so much expertise in CTO and CT imaging, so let me be a little bit provocative to you. Your paper from CT-RECTOR was 2015, so it's been over 10 years. We also have the randomized trial that's positive, but despite that, I feel that it's only a handful of people that are actually using CT in a consistent fashion to guide complex PCI, including CTO. What are the barriers to use this more broadly? You clearly guys have been doing this in a more systematic fashion. I think that historically there's just been a lot of challenges that most interventional cardiologists, yes, maybe with FFRCT and the 3D models for native lesions, it's a little bit more easier to manipulate things. But for CTO specifically, I think people get stuck. So how do we integrate this at a larger level? How do we overcome the barriers? And the provocative part that I want to make is you guys have pushed this field. Why is CT, or what is needed for CT to be central of the global CTO algorithm? We have a randomized trial, we have your scores, we have all this work. What sort of work do we need for CT to be an important element of planning as is done in TAVR?
Yeah, I think there are many barriers, kind of blockades. First of all, we need another, I think, randomized clinical trial, because people still think that, as you rightly point out, Yader, this trial comes from South Korea, right? And people think you do CTO PCI in different manner, differently in Asian countries compared to the West, right? So we use more, I think, the hybrid algorithm. We have a lower threshold to knuckle, and they are more persistent and perseverant with kind of antegrade wiring. So that's a different school of CTO PCI. So I do think we still need more data to make it more ubiquitous. Now, number two, I think CTO PCI operators are a very special group of people, right? We are, I think most of us, apart from Manus, are type A personalities, right? So once they've been doing something all the time, they don't really, and they have good results, at least they think they do. They don't like to change that. Still, I think we do have quite a number of older...
Sorry to interrupt. Whatever happened to the hybrid algorithm? Aren't we hybrid operators and adaptable to change?
Yeah, that's true. It's a very good point, but still. I was joking a bit, but kidding apart, I do think we need to make this kind of technique more ubiquitous. And by saying that, I think we need to implement CT to the cath lab, right? So we need much more CT registration with the new AI algorithms and combining and aligning the CT with C-arm, which we do have in my center, but it's still not adopted so much. We have a chance and getting and nurturing younger operators who are hooked on new techniques I think that's going to make a difference. So basically science, we need more science and more proofs, particularly in the Western population, and then trying to attract younger operators to make a change.
Wonderful. Maksymilian, again, you've been one of the pioneers in this area and one of the few people who saw the value early on to combine the imaging modality essentially with how to perform PCI. And congrats for pushing the field. As you said, there's still lots of room for growth in Europe, in the US, all around the world. But I think the wheels are finally setting in motion. So we're very excited about it. And I think documents like the one you just published with the Polish Society and also the scores and more studies, as you say, are going to be important for down the line. So I get to summarize for everyone for today. CT is a valuable tool for planning complex percutaneous coronary intervention. There are specific findings for CTO, as you've heard from Dr. Opolski, specific findings for bifurcation that predicts side branch loss, specific findings for calcium that can help you decide if you're going to need advanced calcium modification strategies. And having awareness and access to this, and the beauty is many people do have the CT, but most people don't look at it before. Most interventionalists don't look at it before. So it's a question about education, how to get to people more familiar with these tools, looking at the workstations to make this more of a day-to-day practice. So congratulations on all your work so far on this, Maksymilian. And again, we're thrilled to work with you on this and looking forward to more progress in this area.
Thank you. Thank you for having me. Thank you, guys.
Thank you, Maksymilian.